And thanks to all of you for being here, not just those who are here physically in the room, but also those of you who are part of our online webinar audience. I'm delighted to share in welcoming you to the launch of the Philadelphia Public Health Grand Rounds. And I'm proud that this is an activity that is jointly sponsored by the Philadelphia Department of Public Health and the College of Physicians. The college has a long-standing tradition of being a place dating back hundreds of years, a place where people can set aside their institutional loyalties and come together to address issues that are of shared concern across our city. In a sense, it's like the Switzerland of Philadelphia. And I see our collaboration with the college in sponsoring these Grand Rounds as a continuation of that long-standing tradition. I also would like to thank Dr. Woolrich for his enthusiastic support and the support of the college as a co-sponsor of this activity, and also Dr. Robert Sherrar, who chairs the college's section on public health and preventive medicine, for the section's support and guidance in putting this together. There are others from the college who have supported and played a vital role in putting this together as well. And in particular, I'd like to thank Jackie Bowman, who's the director of the college's Center for Education and Public Initiatives, and Carrie Youngdahl, who directs the college's History of Vaccines program. Normally, this section of the Grand Rounds program would be a chance for the health department to give a few updates on its work, but because this is the launch, I'd like to deviate from that formula just a bit to say a few words about why we're doing this. What's our rationale and what are our aspirations? And I think there are really two objectives. The first is to strengthen our public health community. We have a strong public health community, and I see this as an opportunity to make it even stronger. The second is by focusing on important public health concerns for our city and our region, by engaging speakers from diverse parts of our community, and by sparking a dialogue with those of you who are here as members of the audience. I hope that we can generate new ideas and solutions to the challenges that we face, and perhaps generate new partnerships and new collaborations as well. As you've heard, this series is being modeled on the highly successful CDC Public Health Grand Rounds. Excuse me. Which each month focuses on an important public health topic, features a series of short presentations that usually include, as will we, an overview of the epidemiology of the situation, and then, as befits the topic, updates on public health programs, advances, innovations, or successes in prevention or treatment, and critical policy or advocacy issues. In emulating the CDC approach here in Philadelphia, our plan is to focus on issues that are important to public health here and to emphasize speakers from our area and region. We'll be generous sometimes with that definition. Today we've expanded it to include Washington, D.C. Over time, we aspire to include a diverse mix of presenters from our public health community, writ broadly, including our department and other government agencies, universities, including not just those that offer public health programs, but other universities that represent other health sciences as well, community-based or not-for-profit organizations that are an essential part of the fabric of the public health community here, and organizations that work primarily in the policy or advocacy arenas, and others. Obviously, for any given session, it would be impossible to include every perspective that is relevant and important. But over time, we aim to reflect that diversity on this podium and of course to enrich the presentations by your questions and comments as well. These grand rounds will happen quarterly with summer vacation, which means 3 times a year. We welcome your suggestions for topics and speakers. The next session, early in 2016, will focus on long-acting reversible contraceptives. We are also exploring the possibility in future sessions of offering continuing education credits. Our topic today is hepatitis C, a public health and healthcare challenge that exemplifies the value of this type of multidisciplinary approach. Our speakers will be Dr. Kendra Viner from our department. She heads our viral hepatitis program. Dr. Jay Kostman, who is a staff physician at the John Bell Health Center of Philadelphia Fight, and Ryan Clary, who is executive director of the National Viral Hepatitis Roundtable. And the more complete information about them is available on the program. We will hear from each of our 3 speakers in succession, and then Dr. Carolyn Johnson, Deputy Commissioner from our department, and the 3 speakers will come together on the stage to take questions, and Dr. Johnson will moderate that. So, Dr. Viner.
Doing that. All right, well, thank you to the College of Physicians and to Commissioner Buehler for the opportunity to speak today. I have to say that without the support, guidance, and enthusiasm of our Deputy Commissioner and head of the Department of Disease Control at the Health Department, Division of Disease Control, Dr. Johnson, as well as the hardworking hepatitis team that we have at the Health Department, none of the information and data that I'll be showing you would have been possible. So I'm going to talk to you today about a little bit about the work that we've been doing with hepatitis C surveillance at the Philadelphia Health Department. So I just want to begin by telling you the history of how our team was formed. So we've had a viral hepatitis prevention coordinator at the Health Department since 2005. In 2012, our current coordinator, Alex Shurufs, started the Hepatitis C Allies of Philadelphia, a group that probably a number of you are a part of. The mission of this group is really to team up with local specialists and community members to improve the continuum of care for hepatitis C in Philadelphia. In 2013, Philadelphia was fortunate enough to be one of 7 sites nationwide to receive a grant from the CDC to conduct extended surveillance for chronic hepatitis B and hepatitis C in Philadelphia. So at the beginning part of 2013, we spent time basically creating the materials for that program, collecting the team, and sending out a health alert to local hospitals, alerting them that we would be doing this extended surveillance project, and then initiating case investigation. So since that time, we've managed to collect about 2.5 years now of pretty robust data on both hepatitis B and C. So how does hepatitis surveillance work? So all of our hepatitis positive lab results are housed within an electronic database at the Health Department. We call this our communicable disease management system. About 80% of lab reports are automatically entered into that data through electronic lab reporting, and that's mostly from the large reference labs, LabCorp and Quest and BioReference. The remainder of positive labs are entered manually into the system. Within the system, there are workflows for each of our hepatitis investigators, and these are basically line lists of newly reported hepatitis B or C cases for each of the investigators. With each of these line lists, our investigators send out letters to newly reported cases. I'm just going to talk about hepatitis C today, but they also send out letters to hepatitis B patients. And these basically say that the health department wants to contact them about an important health matter. They don't specify what that health matter is, and so a lot of people, when they get that letter, will end up calling us. So it saves us the work of having to reach them by phone. For those patients who don't call us, we make 4 attempts to try and reach them by phone. We also try and reach their healthcare provider who ordered the test. Although I should say that we have a number of contracts set up with medical systems throughout the city for us to directly access their electronic health records or manual charts to review case information. If we're unable to reach patients by phone, our investigators will actually go out to patient homes and try to contact them in person. So there's a lot of work done to collect the information that we need about newly reported cases. Once we're able to reach patients and providers, we collect demographic, clinical, and risk factor information, and all of this information goes back into our communicable disease management system. So I'm going to talk to you a little bit about some of the findings that we've made in these last couple of years. So each year, about 2,500 newly reported individuals are reported to the health department. We are able to investigate about a quarter of those. If we look at the race and ethnicity profile, you can see that most of our cases are African American and Caucasian, although we also have a decent number of Hispanic patients as well. If we look at age and gender, we can see that about twice as many, we have about twice as many males as females, and most of them fall into that baby boomer age range, although we are starting to see an increase in youth cases with hepatitis C. And I'm actually going to show you some evidence of that. So when we look back at surveillance data from 2003, you can see that the distribution of cases by age was really unimodal. So it was mostly baby boomers that were reported to us with hepatitis C. That was also true in 2005, 2007, 2009. You start to see a second peak forming. In 2011 and now 2013, you now see that the distribution of cases by age is really bimodal. We have that baby boomer age range, but we also have a younger population that's emerging. And most of these young cases are new infections, and most of them are injection drug users. So this has really happened in parallel with the increase in opioid drug abuse and heroin abuse in Philadelphia and elsewhere. I should say that this trend that we're seeing, a lot of the other funded sites that have the same grant that we do are seeing the same trend in their jurisdictions. So just looking at our cases by risk factor, you can see that in our younger cases, most of them are reported to us as having what we call a behavioral risk factor. So whether that's injection drug use, history of or current incarceration, unsafe sexual practices, or a tattoo outside of an unlicensed facility. When we move up in age, you start to see more of the cases with medical risk factors. So a blood transfusion or organ transplant prior to 1992, when blood began being screened for hepatitis C, dialysis, needle sticks, etc. So I've showed you our surveillance data. Now I want to go on to show how we're actually using this data to get a sense of how the disease is being managed in Philadelphia. So one way that we use our data is to understand patterns of hepatitis C testing and positivity. So in addition to our surveillance data, we've managed to set up contracts with the major reference laboratories as well as some of the major health systems to obtain negative test results. And what this has allowed us to do is look at Philadelphia. So these are maps of Philadelphia broken down by census tract. And the graph on the left shows the number of people who are positive for hepatitis C out of the people who are tested per census tract. The areas in dark blue are areas where positivity is very high. And the graph or the map on the right shows the number of people who are tested out of the total number of people living in that census tract. Again, the areas with blue are areas where testing rates are high. And what this shows us is areas of the city where positivity is high, but maybe testing is low. And so this can indicate to us areas where we may want to target additional testing campaigns. We've also been able to use our data to better understand current protocols for perinatal Hep C testing. So as Hep C rates have begun to increase among young injection drug users, with this there is increased risk for vertical transmission because it's that young population that's of childbearing age. So the literature says that it's about 5.8% of infants born to Hep C positive moms who are unable to clear the infection and develop chronic disease. And the CDC recommends that all women be screened, all women with risk factors be screened for hepatitis C. AASLD and ACOG recommend screening infants who are born to Hep C positive moms for anti-Hep C antibody after 18 months when there is no more chance of there being maternal antibody present. And Hep C treatment is approved for children over the age of 3. It's still the old regimens, but it's certainly better than not treating. So what we were interested in is, are our healthcare facilities within Philadelphia adhering to these recommendations for screening children born to Hep C positive mothers? So to do this, we took our Philadelphia birth certificate data and matched it to our hepatitis registry to look at women of childbearing age and how the proportion of babies who were born to them. And we found that in the time frame that we looked at, there were over 500 infants who were born to Hep C positive moms. Of those that survived, only 84 were tested, or 15% of the Hep C positive, or babies born to Hep C positive mothers were actually tested for hepatitis C. Of those that were tested, 4 were positive, which indicates that there are at least 27 infants out there just during the time frame that we looked at who are positive for hepatitis C who don't even know that they're positive. And I should say that this rate, while it's 5.8% in hepatitis C positive women, is much higher when we look at co-infected women, so women who have hepatitis C and HIV. So we would expect this rate, or this number of 27, to actually be on the low end of the spectrum. So we've also been able to use our surveillance data to assess racial disparities in disease outcomes. So we've linked our surveillance data to PA cancer registry and death certificate data. We limited our cancer registry data just to liver cancers. And then we looked at outcomes of hepatitis C disease among the 2 main race ethnic groups in Philadelphia, so non-Hispanic blacks and non-Hispanic whites. And I'm not going to show you all the data from this study. I just want to show you one piece of information that was pretty interesting to us. When we look at age at cancer and age at death for African American and white populations without hepatitis C, for just liver cancer alone, we see that blacks are being diagnosed with liver cancer and dying approximately 6 years at approximately 6-year earlier age than whites. When we add hepatitis C to this mix, both hepatitis C and liver cancer or hepatitis C alone, we see that while there's a small drop in the age at cancer diagnosis and death for blacks, we see an enormous drop in the age at cancer diagnosis and death for whites. So we were pretty intrigued by this finding and wondered whether there was a cause of death within the white population that was different from just cirrhosis or death from liver cancer. So we looked at this and found that in the non-Hispanic white population, a good quarter of this population, even though they have hepatitis C and liver cancer, are actually dying from drug overdose, and that this is confounding our findings of age at cancer diagnosis and death. When we remove the individuals who died from drug overdose, the average age at cancer diagnosis and death for our white population goes up dramatically. So another way that we've been able to use our data is to look at testing practices. So everyone, as you know, should really only be screened once for hepatitis C antibody. This really just detects whether someone has been exposed to the virus. It doesn't say whether they currently have it. And if someone tests positive for hepatitis C antibody, they will remain positive for their lifetime. But what we see when we look at our surveillance data is that there are a lot of people in the city who are getting repeat tests for antibody unnecessarily. And a lot of this repeat testing is actually happening in the medication-assisted treatment centers that are treating drug addicts. And when we look at the proportion of those individuals who are getting the repeat antibody tests, who are actually going on to get the confirmatory test for hepatitis C, it's a very low fraction. About 23% of these individuals who are getting tested in the medication-assisted treatment centers who are actually getting confirmed for disease. So duplicate antibody testing is common, and few clients are getting confirmed for RNA. So this is a huge problem in Philadelphia. We've also been able to use our surveillance data to basically build our own citywide cascade, so to provide a real-life snapshot of how Hep C is being managed in Philadelphia. So we estimated, based on NHANES estimates and also estimates of Hep C prevalence within special populations, that there are about 47,000 people living in Philadelphia with hepatitis C. Of those, about 50% have been reported to the health department with a positive antibody test. Half of those, again, have been reported with a positive RNA test. Even fewer are in medical care, and fewer still are on treatment. So people are being lost at all stages in the Hep C cascade. So I've shown you a very grim picture of what's happening with Hep C treatment and linkage to care in Philadelphia. I just want to talk very briefly about what the health department is doing to influence prevention activities and to help move people through the cascade. So the biggest way that we're doing this is by trying in various ways to make our surveillance data more robust. So what we did last year was to change the health code to require rapid Hep C antibody tests, so antibody tests that are usually done in high-risk settings, so community-based organizations, needle exchange facilities, et cetera, and negative Hep C RNA test results reportable to the health department. We've also, as I mentioned, contracted with the major reference labs to obtain negative Hep C antibody test results. So this just gives us a much better picture of not only who's positive for hepatitis C, but also who's being tested. We also have created a number of educational materials for patients. I won't get into this in too much detail. And as well as posters which help to differentiate or help patients to understand the differences between acute and chronic disease and between an antibody and RNA test. We've identified with our surveillance data hepatitis C patients who don't have insurance and also don't have evidence of being vaccinated for hepatitis A and B, which is very important to assure their liver health. And we've tried to get these patients into the health department to get that vaccine. Another way that we've used our surveillance data is through strengthening relationships with community partners. The biggest of these is with Prevention Point, which is really a one-of-a-kind organization in Philadelphia that offers a huge range of services, including syringe exchange, free HIV and Hep C testing, support groups, and now even a shelter for active drug users. In January of last year, we launched a program where we sent our investigators actually out to Prevention Point to draw blood from anyone testing antibody positive to get them confirmed for Hep C. And anyone who was confirmed, we could then have Prevention Point link up with the specialists that they know in their community. Through this process, we've had 150 people linked to care successfully who are RNA positive. We've also piloted a program to address the gap in perinatal Hep C testing. So we've begun to contact Hep C infected moms of children who are coming up on their 2-year well visit to urge them to request an antibody test at their child's visit. And we have some early evidence that this is actually paying off, that mothers are starting to get their infants tested more regularly for hepatitis C. And we're conducting in-services at OB practices, pediatric practices, and birthing hospitals. Ideally, we'd like to move towards a policy change that would require universal Hep C testing of all pregnant women, that Hep C would just be included in the hepatitis panel of testing for pregnant mothers in Philadelphia. And these are just some additional educational resources for pregnant moms and babies exposed to Hep C positive mothers. So for the physicians in the room, in particular, how can you help? Just please report cases to the health department. This is how we best understand the population of Hep C in our city. Spread the word about the importance of testing pregnant women and children born to Hep C positive moms. Be willing to take on insurance companies to cover the new treatments. I think Dr. Kostman and Dr. Truskin, who spent a lot of time doing this, shows that this fight is worth it. It really does pay off if you're willing to engage in the cycle of refusals, and Jay will get into that. Don't turn away drug addicts. There's no evidence that active injection drug users will be less compliant with treatment. And also talk to at-risk patients about naloxone. So I just want to end with this. You know, I think that we've come a long way with hepatitis C. There are wonderful treatments out there that are curative, but we have a long way still to go. So we brought the monster to his knees, but we still need to get a lot more people tested, a lot more people linked into care and treated. So thank you.
I can. And really led to where I am now. And I have to say, to follow up on Kendra's talk, it's really a pleasure in this community in Philadelphia to work with such an amazing group of committed individuals in this area. It really gives us all a lot of opportunity and a lot of hope. And I appreciate the invitation from the Department of Health and the College of Physicians to talk. So, very briefly, background. You heard about some of the surveillance stuff that we're doing in Philadelphia. Just to frame it nationally, hepatitis C is the most common chronic bloodborne infection in the United States, with up to over 5 million people infected in this country. And the important point here as we talk about cascades is that up to 3/4 of those people are unaware of their diagnosis, because we've really failed in our screening attempts until more recently. Important to put in perspective that hepatitis C is about 4 times more prevalent than either HIV or hepatitis B infection. It remains the leading cause of liver transplantation in the United States. And then on top of that, we now have curative therapies for hepatitis C that can decrease the risk for complications of liver disease, liver cancer, but it is really imperative to treat before the disease advances, as I'll talk about in a second. Just to give you a very brief, I'm not going to talk in detail about this, but it is important to realize that hepatitis C comes in strains or flavors, and those are called genotypes. And so there are 3 major genotypes. There are more than that, 6 internationally, but there are 3 major genotypes which are highly prevalent in this country, with genotypes 1A and 1B making up about 75% of the infections in the United States. This doesn't impact pathogenesis too much, although it might, and we're understanding more about that. It does predict therapeutic response to different regimens, and that's why it's important to know that. And so it really is a test that needs to be done once you confirm the diagnosis of hepatitis C in all patients. Now, to understand what happens to somebody infected with hepatitis C, this schematic sort of takes us through that. So people will get exposed to the virus and be acutely infected. The vast majority of those people are asymptomatic, so they don't know they've been exposed. And then about 20% or so will be the lucky ones and spontaneously resolve their infection, but that means about 80%, 75 to 80% will go on to develop chronic infection. And what that leads to is a sequence of inflammation in the liver leading to fibrosis or scarring in the liver, and then progressing to cirrhosis in about 20% of individuals who are infected over a 20-year period of time. Once you get to cirrhosis, then the complications of end-stage liver disease, either decompensation or hepatocellular cancer, occur at a rate of about 2 to 5% per year. There are certain things that speed this up. Going back to my initial comments about the HIV co-infection, we know that if you look at someone who's infected with hepatitis C and we look at that 20 to 25-year period, if you're HIV infected, that 25-year period becomes around 10 to 15 years. And if you're HIV infected and drink alcohol, and you don't have to drink much, on average about a drink a day, then that time period will go down to 5 to 10 years, which really explains why when we started seeing people developing clinical complications of liver disease, we saw it in that time frame. Other perspective is, this is from a study that was published in the Annals of Internal Medicine now a couple years ago, but really just to understand that the mortality rate of hepatitis C in this country now exceeds the mortality rate of HIV and far exceeds the mortality rate of hepatitis B. And this is a point that is a testament to the advances in HIV therapy, which is a good thing, but it's also a testament to the progression of hepatitis C and what we see, and realizing that this is only the tip of the iceberg with this disease. And so if we think about how long it takes to progress from infection to either cirrhosis or hepatocellular cancer, and we realize when the peak of exposure in this country may have been in the past, not even looking at those young people that Kendra talked about in her talk, then we realize that the peak in the clinical complications of this are really not going to be seen until about 2020, when we will start to see all those people who were exposed 20 to 25 years ago present with their end-stage liver disease and liver cancer. So that really, that hump in that graph there is what we're going to be dealing with over the next 10 to 20 years. Now, Kendra talked about the care cascade in Philadelphia. This is from a meta-analysis that was published a year or so ago to show you that that is reflected all over this country. And it's really, it's almost, as a physician and a healthcare provider, it's almost an embarrassment to look at those percentages drop down, where you see the number of people infected, and then you go to the far right of the slide, those who achieved SVR or cure. SVR means no virus after treatment is done, and we're less than 10% of the individuals. This is in the context of having regimens which are now curative and incredibly easy to tolerate. So it really is a commentary on what we have ahead of us to do. The other point of getting people into care is that it's not just a matter of treating their hepatitis C and getting rid of the virus. There are a lot of other opportunities, and what I like to say is what we really should be doing is using hepatitis C as an entree into effective primary care for those individuals who are infected. Because we're going to cure their hepatitis C once we can get drug for everybody, but then we're also going to be then left dealing with those other complications, both of hepatitis C and of living in the United States. And if they're in care, then we're going to have a better opportunity to do that. So, for instance, we can ensure immunizations for other hepatitis viruses as well as other infections that are preventable. We can use the opportunity to emphasize drug and alcohol cessation and really a harm reduction program that includes those things. We can work on dealing with weight loss, which may or may not be associated with the disease, adherence to medications, safe sex counseling, and referrals when needed. So really, all the buzz in this field, or a lot of the buzz in this field, has been around treatment. And it really is an amazing accomplishment to look at how far this has come over a short period of time. If we look at this slide and we see back in the mid-1980s was when interferon was approved to treat chronic hepatitis C, and we saw response rates, and so those rates of SVR, again, that equates to cure of the infection. No virus once treatment is done 3 months or 6 months later. So cure rates with interferon alone of only about 5 to 6%. And then you can see the advances with better interferon, with the addition of ribavirin, and then finally, two major advances until recently. One was the development of what's called pegylated interferon, which is basically a long-lasting interferon that can be given once a week. And then the addition of the first orally active, direct-acting agents against hepatitis C. We still don't know really why interferon and ribavirin work for hepatitis C, but we know that the direct-acting agents directly affect the virus itself. And so when those initial ones were available on the market, cure rates went up to as high as 75%. And we are now in an age where we can cure over 90% of individuals with chronic hepatitis C, which is really an amazing accomplishment. So we have to think about who should be treated. We're going to identify these people. There are now, and at the bottom of this slide you see a website, hcvguidelines.org, which is a real-time updated website that is actually very useful for those who are interested in this disease. But it includes a set of treatment guidelines. And I think the first point is by far the most important, that anybody who has chronic hepatitis C with evidence of virus in their blood, that HCV RNA that's detected, should be considered a candidate for treatment and potential cure. That's the most important thing. There has to be prioritization, and the prioritization really right now has to be because of barriers that I'll talk about in a second. But we do that by sort of giving highest priority groups. And so you can see that those who are given highest priority are those with more advanced liver disease. They're at higher risk of the complications of disease. Also, those who've already gotten a liver transplant, because hepatitis C is a worse disease in that population, and then some extrahepatic or complications outside of the liver. But it's also important to realize that those who have other conditions should also be considered at high priority. Those with less severe but significant fibrosis, those who have co-infection with other viruses, those who have other liver diseases, and then those with some other symptoms. In particular, those who are at risk or whose risk of hepatitis C transmission is high should also be considered at high priority for treatment. And that includes active injection drug users and then men who have sex with men with high-risk sexual practices where we've seen outbreaks of acute hepatitis C over the last 5 to 8 years or so. It's important to understand what we need to do to evaluate these people, and the important questions to ask are just shown here. Have they been treated before? If so, with what? What is the degree of scarring in their liver? It's still important to know, and the real question is, does somebody have cirrhosis or not? Because that will influence not just their Hep C treatment, but what else we do for them. And there are several ways to determine that, which I'm not going to go into detail about, but just understanding that if they do have cirrhosis and it leads to decompensated disease, that they may need to be considered for transplant evaluation. But one of the other things to understand is it's important to treat people because people have improved health if they get treated, regardless of the stage of their liver disease. And so here is just some data. There are now multiple studies that have looked at this. This particular study looks at the far left of that graph under all-cause mortality. What you can see is the yellow bars are those who were treated and didn't cure. The blue bars are those who cured. And you can see this is not just improvements in liver health. This is improvements in health. Mortality rates are lower when people are treated for hepatitis C and get cured. That previous slide was in the interferon era. There is also now data from the non-interferon or all-oral drug era that basically shows the same thing. Not to go into details about it, but in studies with different drug regimens, overall health is improved with curing hepatitis C. And there are benefits to treating early rather than waiting until that fibrosis progresses to cirrhosis, which unfortunately in a lot of cases we are forced to do by insurance requirements right now. And so there are a couple different retrospective studies that have looked at this, one in the VA that actually looked at a case registry and one that looked at more of a modeling approach, and both of them have shown that early treatment prolongs survival and quality of life compared to waiting until people progress in their disease. So we know that treating early works. We know that treating is effective. What about what to treat with? And I'm not going to, this could be a whole talk that goes long, and I'm not going to go through a lot of bar graphs. I'm just going to show you what the drugs are that are currently available, as shown on this slide. The direct-acting term refers to their targets in the virus, and that's in the light blue above there. And then you can see the individual drugs below there that are currently available. So these are now FDA-approved drugs that we have available to us to treat hepatitis C. And if we look at the recommended regimens, then you can see that there are 6 or 7 recommended regimens for the most common type of hepatitis C, but we don't use 3 of them anymore because they have interferon. So none of the recommended regimens for genotype 1, the most common cause of hepatitis C infection in this country, include interferon. We have passed the interferon era with this disease, which is really, it is, for when you talk to patients who went through interferon, you realize what that means to people to be able to treat without having to use interferon. And it's not a matter of one regimen's better than the other. They all work. They're all incredibly successful. Some are more pills than others. You can see in the green there, multiple tablets versus single tablets, different times in a day, but it's all pills, and it's either once or twice a day. And the response rates, which I just show you here to look, if you look at that SVR column there, you can see that everything pretty much is above 90%, most of them above 95%. So whether or not you treat with a more complicated regimen or not, there are even some people who you can treat for shorter periods of time, like 8 weeks. You're going to get cure in over 90% of those individuals. And you're going to get it even if people were treated previously. So what we have is incredibly effective therapy that is very well tolerated. Not even only for genotype 1, but we now also have it for the other genotypes. And I just put this up to show you. We used to say, comment that genotype 3 was the easier one to treat. We now know that this is actually one of the biggest challenges we have in dealing with this population. The regimens, although good, are not quite as good, and it's one of the areas where we really need to do some more work. And then another point is that we used to say that people with HIV infection need to be approached differently, and that is no longer true. Someone who has HIV co-infection should be treated just as if they had HCV mono-infection. The drugs work, they work just as well. There's no reason to withhold therapy. We just need to understand the potential for drug interactions. And then we have new drugs, even more coming. So the ones at the top of this path down the road are drugs that are currently under evaluation, and some of which will be available very shortly, and will give us even more single pill options. Not only single pill options, but shorter periods of time. Most studies have shown that 6 weeks is probably too short for most of these regimens, but 8 weeks is probably the shortest that we can go with most of these regimens in selected patients. I wanted to make a couple comments about where we are now and what the barriers are in closing, because you'd think, okay, so we have these drugs, we can identify these people, this is not going to be a problem after another 6 months or so. And that's very far from the truth. There are huge barriers to treatment, and Kendra alluded to some of those in her talk. And a lot of this stems around the fact that the highest prevalence of infection is among persons who use illicit drugs. Most new infections are in this population, and very few injection drug users have really been encouraged or want to pursue treatment. Some of those are from patient barriers, as we see here. There's coexistent mental health disorders, there's social instability in this population, they may not have access to health care. But there are also provider barriers and institutional barriers. There is a lack of training and expertise in the treatment of hepatitis C infection in providers who actually do maintenance treatment, whether it's methadone, Suboxone, or others. There is also a real unwillingness amongst providers outside of that arena to treat not just HCV infection, but injection drug users in general. A lot of that is because of failure to establish a multidisciplinary team, and because, frankly, it can be frustrating for some people to take care of patients who are active injection drug users. They miss appointments. Some practices will kick people out of their practice if they miss 2 or more appointments, and that's not a real good, conducive environment to welcoming patients into the practice. But we need to understand that there is a window of opportunity to treat these individuals. If we work together as a team, we can work on adherence to treatment, we can help with housing, we can help with nutritional supplementation, we can get access to other health services, we can work on other harm reduction approaches that will help people overall, not just with their hepatitis C. And there are challenges, and I thank my colleague, Dr. Truskin, for this slide. But this is what we go through on a day-to-day basis with this. We submit an authorization for drug. It often, not often, it always gets denied. We appeal it. It will get denied again. We do a second appeal, and it will be denied again. That will lead to then a peer-to-peer discussion where you get an individual who may or may not know anything about hepatitis C on the other end of the phone. That often will be a denial as well and lead to maybe making a grievance, which still about 30%, if not more of the time, results in ultimate denial of drug. Requiring on average about 8 hours of staff time per patient, and on average 2 to 4 months to go through that process. So you can see how that's another feature of the cascade. You will lose people as you're going through the cascade because they thought they were interested in therapy, and then you're telling them you can't get drug for them. It's also important to understand why people might not respond and I want to focus here just on the adherence piece. So this is data from interferon era, where using data from the VA, it was looked at adherence in intervals over time in interferon and ribavirin. And you can see early on, this was based on pharmacy refill. So very good adherence, close to 100%. Then as you go through over time, there's a decline with both the injectable and the oral drug. And actually, with the injectable drug, there was a decline of about 3% per 12 weeks. But with the oral drug, it was even more over time. So this is an area that really needs further study, the ability of this population to adhere to therapy and how we can work on that. And then finally, one of the other issues we deal with is whether or not reinfection can occur, because we know it can. And this is data that was actually presented very recently at the European Liver Meeting a couple months ago, looking at people after cure developing what we call late relapse. And so you can see that the majority of these were shown to be reinfection, and it really emphasizes the reason why a more complete harm reduction program needs to be in place there to try to minimize that. So in summary, we have safe and effective curative regimens for people who are living with the most common blood-borne infection in the United States. Unfortunately, a minority of patients who are living with the virus actually have access to these curative regimens. Part of this is because there are a lot of different barriers, both patient and provider, but we should not be allowed to use those barriers as excuses for people not getting treated. And it's really incumbent on us as a community, both public health and medical, to work together so that we can achieve a goal of hepatitis C eradication. I thank you for your attention.
Thank you very much. Hello, thank you very much to the College of Physicians and the Department of Public Health for inviting me and including the National Viral Hepatitis Roundtable and the Advocacy Voice as part of this discussion. My name is Ryan Clary. I'm the Executive Director of NBHR, and I'll talk in a second about NBHR and our work. And I'm just going to talk briefly about what's going on at the federal and somewhat at the state levels to advance hepatitis C policy, advance access to treatment and prevention, and secure the funding desperately needed to eliminate the epidemic in the United States. So just some brief background on NBHR. We were founded in 2003 and really founded by a small group of hepatitis B and hepatitis C advocates who really felt that there was not a national voice, particularly in Washington, D.C., fighting on behalf of people living with and affected by the epidemics. We work on hepatitis B and C. For tonight's purposes, I'm just going to talk about our hepatitis C work, but we do work on hepatitis B, and you're welcome to check out our website to learn more about that work. We are now a coalition of about 300 organizations around the country. That number is growing rapidly because of all the opportunities and the challenges in fighting hepatitis C in particular, and also in hepatitis B. And those are everything from small grassroots organizations that focus just on viral hepatitis. Of course, funding is pretty scarce for hepatitis, so there aren't a lot of hepatitis advocacy organizations around the country. So we work also with a lot of organizations where there's some sort of impact with viral hepatitis. So that would be HIV organizations, public health organizations, and harm reduction. Our work, our strategic vision is really guided by our 11-person steering committee. That steering committee is voted directly by our membership, and Philadelphia is represented on our steering committee. I don't know if anybody knows Sherry Cohen, who's the director of public health for the Hepatitis B Foundation right here in the Philadelphia area, was elected to the steering committee a couple of years ago. And we worked on our mission through advocacy, education, and coalition building. I just put up our mission and vision, which I'm not going to read word for word, but I was really excited when last year staff worked with our steering committee to rewrite and rework our mission and our vision and really call out what is really necessary in order to do what we know is possible, which is to eliminate hepatitis B and hepatitis C. We work domestically, so I'll say in the United States, but of course we want to see that done globally. And we really believe the tools exist to do that. We've heard about those tools tonight, but we know that we have a lot of barriers. Those have been talked about already tonight, and we actively work on those barriers in order to achieve the goal. So a little bit about our 2015 advocacy priorities, which I think really mirror what most advocates are working on around the country. They don't represent all the challenges and all the policy issues that we're facing, but some of the key ones. Hepatitis C treatment access is our #1 priority. I'll talk a little bit more about that. We've already heard about that tonight. Also implementing the Centers for Disease Control and Preventions and the U.S. Preventive Services Task Force's hepatitis B and C screening recommendations. We have great recommendations, but they don't really mean a lot unless they're really implemented throughout the country, throughout healthcare systems, and that providers and patients really know about them. We fight every year for federal funding for viral hepatitis through the appropriations process, very challenging as it is for a lot of health and disease and social justice and education groups. And we work very hard on drug user health, and we've heard tonight on why that's really important. We really can't impact hepatitis C, particularly among new infections, among the new wave of infections among young people who are injecting drugs, if we don't address drug user health in this country. So just to dive in a little bit deeper on some of these issues, we heard a little bit about the barriers in hepatitis C treatment access. These barriers are absolutely discriminatory in our opinion. We're doing a little bit better in Pennsylvania thanks to some great advocacy. Pennsylvania's Medicaid is starting to relax the restrictions a little bit in the fee-for-service area. And the nation is really watching states where this is happening and seeing how advocates are getting this done, see how advocates work with payers and with government to reach solutions. This is not happening around the country. There's Pennsylvania, California, Connecticut, and Massachusetts are the 4 states that have really worked successfully to relax a little bit their restrictions. But in other states, you're seeing things as bad as in Illinois. You have to have stage F4 fibrosis before you are considered for curative treatment. So you have to have cirrhosis. That doesn't even match the highest priority list in Dr. Kostman's slides. So those, and substance abuse restrictions, people have to be 12 months, without using substances and submit urine analysis or submit to urine analysis just to get curative treatment for a chronic or for an infectious chronic disease that is often life-threatening. So anyway, what we're doing around hepatitis, I get very passionate on this because it is just really, really obscene to see that we have these tools available for people to save their lives, to prevent new transmission through curative treatment, and to find these discriminatory barriers that I really believe largely is based on stigma around hepatitis C and knowing that there's not a very strong voice in this community to fight back. So we do a lot of work with the Centers for Medicaid and Medicare Services, trying to get CMS to send some guidance to state Medicaid saying, you really have to relax these restrictions. Here's some examples of states that are doing this well. Here's some problematic states that we want to work with. We've worked really hard. It's been a big battle with the media. Please raise your hand if you've read a news article or seen a TV story that talked about the $1,000 a pill for hepatitis C. I think many of us have. That's what the media has focused on really since new treatments were FDA approved. And we know that price is an issue. We know that cost is an issue. But we also know that the story also is that people living with hepatitis C, and up to 5.2 million in this country, have hope, can be cured of their disease. And that story hasn't been getting out, and about the restrictions that have kept people from being able to be cured and move on with their lives. We try to really support state-level advocacy, like the great work being done in Pennsylvania and bringing advocates together to share best practices. We provide a lot of tools and resources on our website that I invite people to look at. Research is coming out every week that bolsters our case for expanding access. And we also host a national listserv of people who just want to share ideas and connect with one another on this advocacy, and you're welcome to contact us to get involved. Excuse me. So implementing hepatitis C testing recommendations. We had a really, really great victory in 2013 when the U.S. Preventive Services Task Force, which is really the body in the United States that makes recommendations around preventive services that then payers then look to on whether or not to cover those services, and providers look to on whether or not to perform those services. Until 2013, the USPSTF had an I grade for hepatitis C testing, basically said there wasn't enough evidence to even show that anybody should be tested, even at-risk folks. And we were able to get that changed to a B grade for ongoing testing of at-risk individuals, but also one-time testing for anybody born from 1945 through 1965, and that's the baby boomer generation. And we talked about that. That's because 75% of those cases, of hepatitis C cases in the United States, are in that birth cohort. And thinking that why not just have one-time testing of everybody in that birth cohort to try to identify cases. Not everybody identifies with the risk. Not everybody knows how they got hepatitis C many, many years ago. But we know that folks within that birth cohort, many have been living with hepatitis C for a very long time who don't know it and are at really great risk for advanced liver disease and liver cancer and the need for a liver transplant. And it's really urgent to identify those folks. So we got the B grade. It was a little bit of a fight. We were able, actually one of the few groups disease groups that was able to get a draft grade of a C to a B through the public comment period. So that was a great advocacy win. And so now under the Affordable Care Act, because we have a B grade for hepatitis C testing, most private insurance companies and all expanded Medicaids around the United States have to provide that at no cost, which is really, really big and really great. Now, under Medicare, we had to go through Medicare's process, which is called the National Coverage Determination process, and we succeeded with that as well. And last year, Medicare announced that it would cover hepatitis C testing, one-time test for the birth cohort, ongoing test for at-risk individuals at no cost. So and this is huge, of course, when you look at the birth cohort and how many people in this birth cohort are aging into Medicare on a daily basis. The one challenge with that is CMS gave a pretty narrow determination and said that this would have to happen in a primary care setting. And we know that one of the biggest places where that's a problem is we've seen how the importance of testing in the emergency room setting, and there's some great studies around that we could get into. And then also, of course, there's other healthcare settings besides the primary care setting, substance abuse centers, mental health services, where people might access hepatitis C testing, but if it's not provided, it's not reimbursed at no cost, or it's not reimbursed or provided at no cost, then there's that barrier that we talked about. So also doing work with CMS to provide education and outreach. There's a yearly sort of Welcome to Medicare booklet that goes to new Medicare beneficiaries, and we continue to try to push to get our information included in that. And then a piece of legislation at the federal level that would help towards implementation. Of course, a lot of these services require funding. And there's the Viral Hepatitis Testing Act. That's a bipartisan bill, been introduced almost every session of Congress for the past several years. And if passed, it would authorize $80 million over 3 years for targeted hepatitis B and C screening around the country. So another opportunity to talk to our members of Congress about the importance of testing. So appropriations, which is funding for viral hepatitis. So current federal funding for hepatitis B, A, B, C, all viral hepatitis, there's one line item in the federal budget, and it's for the Division of Viral Hepatitis at Centers for Disease Control and Prevention at $31 million. That may seem like a lot of money. These are pennies compared to what a lot of other disease and health groups get to be able to fight the epidemic. I worked in HIV for 17 years, very, very proud of what we've built up in funding. So about $750 million a year is the prevention line item for HIV at CDC. I don't in any way say that money should be taken from HIV for hepatitis. I say this to show, as we saw, when you invest in HIV, in care and prevention and research, you see the benefits and the great strides we've made in the epidemic. And we have to have parallel investments in viral hepatitis. So this talks about where some of the money goes, the viral hepatitis prevention coordinators. Every state has a coordinator, and 3 cities have a coordinator, and Philadelphia is very lucky with Alex to have one. And the coordinators are really the soul and the heart of the nation's response to viral hepatitis. They work within state and in Philadelphia's case, city government with very, very little funding to actually have his or her own programs, but they really work valiantly with what they have to be able to do what they can with advocates and really expand services. We've done a great job working with the President's administration, and we were very excited that in February, when the President released his budget, he called for a doubling of funding. So $62.8 million is also not a lot of money, but it's doubling of money in a very, very tough economic and political climate. Unfortunately, the President's budget is the President's budget. It's Congress who appropriates funding. So Congress looks at the President's budget and then makes its own decisions. We started going through the process this year. The House of Representatives said, we'll give you the same amount as last year, about $31 million. A little bit better in the Senate. The Senate said, we'll give you a $5 million increase. So if we were or are able to get a final budget for the fiscal year, there's a chance we would get a little bit of an increase because the Senate has to negotiate with the House. But I think we all have seen what happened. There was almost a federal shutdown. Congress passed a temporary spending bill right before the end of the fiscal year. They're going to look at it again in December. We are seeing what's happening around sort of leadership in Congress issues and whether we'll get a final budget that's actually negotiated, or they may just pass kind of a long-term spending bill that's based on last year's numbers. So the chances of getting a meaningful increase are probably pretty low, but that does not mean that we shouldn't stop. And it's really, really important to keep talking to our members of Congress about the need for increased funding. 5 minutes, okay. So we're fighting hard for next year as we keep fighting for this year's funding. It's just a cycle that kind of never ends. We're asking the President's administration to actually go bold and ask for $170 million in the budget that comes out in February. And these are some areas where that money would help out. It would really expand what we've been able to see organizations and community groups and coordinators do with limited funding. There's some great advocacy opportunities next year. Hepatitis on the Hill is bringing advocates to DC to talk about the need for more funding. The ASLD, the liver disease doctors, come to DC in March as well. And Caring Ambassadors, which is a really great national organization, has its own advocacy conference and Hill Days in May. And I'd be happy to talk to anybody about how you might get connected to those. In most cases, there's funding and scholarships available to go to DC. And it's just really, really vital to come and talk to your members of Congress about this. Okay, I don't want to miss out on talking about hepatitis C and drug user health. We've heard about the huge problem we're seeing. We've got the epidemic among baby boomers, and now we have the epidemic among primarily young people under the age of 30 who are becoming infected with hepatitis C through the use of injection drug use. These are some states where the CDC has documented some hepatitis C outbreaks, but I think we know that there's far more states than this and rapidly becoming a national problem. This is the opportunity around this, is it's really renewed the dialogue around the importance of allowing federal funding for syringe exchange and syringe access programs. And we're starting to see some members of Congress who historically have been very resistant to this, seeing what's happening in their state and starting to get it a little bit and being a little bit more open to talking about at least some negotiation around that. So I think that's something you're going to hear more and more about, and a lot of need for advocacy. The President just today went to West Virginia to talk about the opioid and heroin crisis, which is huge. And of course, we know the connection with hepatitis C and this crisis, and it provides a lot of opportunities to make sure that HIV and hepatitis C are inserted into these discussions. Unfortunately, treatment access restrictions also have a disproportionate impact on these individuals because many state Medicaids have restrictions around current or recent substance use. And also, these folks are not going to have advanced liver disease because they're newly infected, so they may not find themselves eligible. So we have to fight for access for anybody who wants to be cured and has a provider who wants to work with them to be cured. And I really believe that we have to work to prevent new infections and address this epidemic with the same urgency that we do rightfully around identifying and curing people who have been living with hepatitis C for a long time. Very, very quickly, there's a couple of great plans. One is the Health and Human Services Action Plan for Preventing, Caring, and Treating Viral Hepatitis. This is the nation's basically action plan for, here's everything, if we did everything in this book, basically, we could really get a handle on this epidemic. And it's a really great blueprint, and there's a lot of champions in the administration who are working to implement it. But the challenge is funding. Without funding, it's really hard to drive home a lot of these strategies. And then the Institutes of Medicine is has begun a process to look at the question of whether we can eliminate hepatitis B and C in the United States. And if, as part of this initial process, the answer is yes, which many of us believe the answer is yes, the IOM will go into a much longer process and actually release a report with policy recommendations that will move this country forward. Now, the IOM 5 years ago released a report talking about hepatitis being the silent epidemic. And to go in 5 years from talking about a silent epidemic to a bold statement saying we can actually eliminate these diseases kind of shows how far we've gone in advocacy and where this country needs to go. These are just some ways to make your voice heard. They're very simple, but if you take a moment to call or email or tweet, I don't know how to tweet a member of Congress, but I know it can be done, and we can help you figure it out, or have a meeting, even at the district level, to talk about the need to provide funding and leadership to fight viral hepatitis, and if you're a medical provider, to talk about your patients, and if you're living with hepatitis C, to talk about your life, and if you're a social service provider, talk about the people you're serving. That really does have an impact on members of Congress. Bipartisan, doesn't matter. They hear how it's happening in their district and how it impacts people's lives. That's a lot more effective even than I can do having meetings with members of Congress kind of representing NBHR. And those are some messages that you could carry: support funding, eliminate the federal ban on funding for syringe access, support the Viral Hepatitis Testing Act. And then finally, these are just some ways to get involved. Please go to our website and click join if you're an organization. Your organization could be a member. If you're an individual, we'll get you on our listserv. We have action alerts, conference calls, policy updates. If you're not a part of HepCap, I would be. There's no other group like it in the country, bringing together hepatitis B and hepatitis C advocates, providers and people living with hepatitis, and advocates and activists to create a strategy to move forward. So you're very lucky to have that here in Philadelphia, and I encourage everybody to get involved as well. Thank you very much.
Yeah, come on up to that. Well, I'd like to start off by thanking our speakers for wonderful presentations that were enlightening and extremely timely. I was impressed by how much data from 2015 was presented. So what we'd like to do now is open the session for questions and comments. There's a microphone at the center aisle, and I'd like to ask you to step to the microphone so everyone can hear you. And also introduce yourself and say anything about your involvement with Hep C that you'd like to. So please.
Hi, my name's Ed Viner. I practice over in Camden, where we have lots of hepatitis C. There must be a large but finite number that's calculable that it would cost to eliminate this disease. Can somebody tell me what that might be? And compare it, that second part of the question is, how does that compare to the cost of taking care of all these end-stage liver patients who are going to die of either hepatocellular cancer or end-stage liver disease? And what's the difference? And is anybody looking hard at that? I'm sure you guys are, but I mean government-wise.
There have been a number of cost-effectiveness studies looking at exactly that issue, and I don't remember I don't know, Jay, if you know what the total cost would end up being, but it definitely is cost-effective to treat people now rather than to wait until they come in later with end-stage liver
I
disease.
just had a patient die who was told for many years that he wasn't sick enough to get a liver, and when we finally got him a liver the last day before he's going to get it, they found that his hepatocellular cancer had gotten into his vena cava, and he was no longer eligible, and he died. So that patient cost hundreds of thousands of dollars in his last year or two of life. Why can't we see the wisdom of doing this?
So I think part of that,
use the mic, okay? I think part of this is that we don't really know the cost of drug in a good way, because there is not transparency over how much individual pharmaceutical benefit managers pay for drug. And so it's hard to get a good handle on that number, believe it or not. I think you're right. It should be something that is very easy to figure out. But I think, as Kendra said, there are studies clearly that show that early treatment, there was just another one actually, I can't remember where I saw it, that showed early treatment, in other words, treatment before you get even to stage 2 fibrosis, is cost effective when you, and by all measures that we judge cost effectiveness. So, but I think that it is, as Ryan said, you're focused, the press is focused on this $1,000 for a pill, and that's where a lot of the energy has gone, rather than looking at it as, if we treat now, we will prevent all these downstream complications, such as the one you described in your patient.
Seeing no line behind me, may I ask another question?
Of course.
The patients who are cured, as it would appear to be, what happens to them end-stage liver-wise and hepatocellular cancer-wise? Are they still could die of their end-stage liver fibrosis or their cancer, or get cancer? Or can you comment on that, Shay?
Yeah, so I think your question is, if you wait until people are cirrhotic and then cure them, you're still going to have to deal with the complications of their cirrhosis. There are data, though, that show that fibrosis does regress after cure, even in cirrhotics. And it actually happens quicker than you would think. So, again, these drugs have only been available for a couple years, but in studies that have looked a year down the road, by looking at changes in fibrosis, there are significant improvements in fibrosis. Now, if there's a scar there, as you well know, you're still potentially at risk, particularly for cancer. So I think that is still an open question. Clearly, you still need to monitor those people for the development of cancer.
Thank you.
If I could just quickly add on the first question, the cost question. One of the challenges that we're facing is that, most payers, Medicaids and private insurance, I think it's hard to make the argument that, if you invest in curative treatment, you're going to save money down the line, because they know that a lot of those patients won't be in their system by the time the savings are realized. Medicare, we've been able to have that conversation because people who are in Medicare generally stay in Medicare. So what we've just called for is, we just need stakeholders to come together and look at this from a national perspective and create a long-term plan. Because if we go kind of payer by payer, I think they're just looking to kick the can down the road.
Thank you.
Hi, my name is Deborah D'Alessandro, and I'm at the Health Federation of Philadelphia, which is the home of HepCap, Hepatitis C Allies of Philadelphia, that was mentioned. And HepCap and the Health Federation and the Philadelphia Department of Public Health had a conference in May in Harrisburg that I wanted you to just mention some of the, since at least, actually you were, 3 of the 4 of you were there. All of you were there. Some of the key steps that have come out, particularly since Ryan mentioned we are seeing some movement in some of our state Medicaid plans about access.
Yeah, so Philadelphia was one of 3 sites nationwide to receive funding from the CDC Foundation. Oh, all right. To host a state summit. So Alex, who is our hepatitis prevention coordinator, along with the Health Federation, organized this and really brought together stakeholders from around the state in all kinds of settings. So, pharmacy, a specialist, community-based organizational leaders, syringe exchange programs, docs, all into one area to sort of discuss issues around hepatitis C in the state. And as a result of the momentum that kind of was built from that meeting, the state has actually focused much more attention on hepatitis C than it had prior to that meeting. So while Philadelphia, because of the surveillance grant and other funding that we have, has been focusing on hepatitis C for a couple of years. The state really hadn't been as focused. And I think now, we have the Physician General, we have the Director of Drug and Alcohol, and a number of other individuals who are really taking positive steps towards addressing this issue on a statewide level. So that's been very exciting.
And can you speak to what the current status of the sobriety requirement is for the insurance companies in Philadelphia?
So for people with medical assistance in Pennsylvania, the first group that met was the P&T Committee for the State Medicaid Program Fee for Service, which on July 20th changed their requirement to no longer have a sobriety requirement or a urine drug screen before approval of hepatitis C treatment. That was actually a huge thing. That has trickled down to some of the Medicaid managed care programs, but not all of them in Pennsylvania. And so that's a program in evolution, let's say, but it is clearly a big step. And I think it emphasizes it doesn't mean that you ignore that issue. It just means that that's not the obstruction to treatment. I think it's an example of how you can take someone who is an injection drug user, even currently still using, and say, okay, we can cure your hepatitis C, but then we also have to continue to work on your drug user health issues, as Ryan really went through very nicely.
My name is Noelle Hanrahan, and I'm a journalist and an investigator. And the population that I'm looking at or concerned about are state inmates in Pennsylvania. We have 55,000 state inmates. Maybe 17 to 40% are infected with hepatitis C. And we also have the State Department of Corrections, as well as the for-profit provider of health care, Correct Care Solutions, having no protocol for treatment in place. There's currently a class action lawsuit that was filed in June for access, and there are other lawsuits as well. Abu Jamal versus Caresti trying to get care. And I wanted to know from you what you see as a viable opportunity to educate, treat, and work with those populations, those very important populations that are going to be returned to our community and who are part of our community, as there are fathers, our brothers, or mothers. They're people that we care about.
I'll just, from the policy side, there's a really growing advocacy movement at the national level. You may already be plugged in. There's the National Hepatitis Corrections Network, run by actually Michael Nimberg, who's the chair of NBHR steering committee, who I can connect you with. There's the lawsuits. One of the biggest challenges is, state prisons don't have the same sort of negotiating power on drug pricing as, Medicaid gets sort of an automatic discount, and some of the other programs do as well, VA, but that's one of the biggest challenges. But there's a big growing movement, and a lot of the activists from the HIV world are starting to work in that area. There's some folks up at Yale, so I could talk to you afterwards about some of the folks who are working in that area on the policy side.
I think from the clinical side, what I can add is I think it's a really complicated issue, but one that needs to be addressed, and it depends partly on the prison system. So I've gone to the Philadelphia prison system. I've spoken to the primary care providers there, focusing more on, because of their length of stay, and that the length of stay in that prison is often short, but using it as an opportunity to say they're testing everybody. So you identify people. Once you identify them, this is where we need to work to develop a linkage to care system after they leave the prison system. So I think that's one opportunity where it really does require, and it gets sort of past that issue of who pays for the drug, which is really one of the major issues now for those in the prison. But that's an area that is, I think, actively being worked on. For those who are in for a longer period of time, where they would be ideal candidates for treatment and cure, because you can give them, you can give drug every day, you can know that they can take it. There, I think it's going to take more discussion that involves payers, because who pays for drug is really the major thing at that point, and that's certainly something that we as advocates and provider advocates should be a part of, but we need the people from the prison system involved in that as well as from the people who negotiate those prices for them. So I think it's sort of two separate issues.
So in the younger population, that it's primarily behavioral risk factors. So IV drug use and, you know, unsafe sexual practices, et cetera.
How easy is it to be transmitted sexually? As easy as hepatitis B, or
It's you know, it's primarily seen, I think, in MSM and other populations that may be engaging in more rough sexual practices where there may be risk of blood transmission or blood-to-blood contact.
So, I mean, if we know the mode of transmission, as we thought, about doing any contact tracing to identify the contacts and test them.
We would love to do that. I mean, that's really kind of comes down to a resource question. So it's hard enough with what we have to really follow up with the people who we know are infected, much less all the contacts. I mean, ideally, that's what we need to do in order to stop the cycle of transmission. I mean, you're absolutely right. That's what HIV does. Hepatitis C needs to do that too. Walter?
Well, that was the former director of disease control for the city, so that was good to hear. I have a question, since obviously funding is a big issue here, whether there have been comparable studies within the VA or in other countries that have shown that they've been able to take a cohort of people who are screened for Hep C and then bring them into a sustained viral response when they have maybe a more universal healthcare system for the people who are their patients.
So actually, the VA has traditionally the numbers of people who've been able to be treated in the VA have been extremely low, and that's changing a little bit now as drug availability and cost has come down. But for instance, just recently, the VA ran out of money to treat hepatitis C, and they worked with a bunch of community providers who agree, including me, to agree to accept VA patients to treat them because the VA didn't have money to continue to treat those patients. So that's something that needs more work. They're probably the best examples of those, particularly in high-risk populations, are actually in Australia, where there's a very active community where they've worked really hard at incorporating Hep C treatment into different maintenance treatments for drug users, mostly methadone, but also Suboxone, and where they've done studies that have looked at on-site care for hepatitis C within those programs and shown that they can very effectively treat and cure the majority of people who go through treatment. But even in those settings, a big block in the cascade is going from identification of infection to linkage to treatment. And so that's even in an enclosed system. And why that is it's all those barriers that we talked about, both on, there's a lot of suspect on the patient population about providers who may not show respect to people who inject drugs. And then there's clearly a lot of barriers on the provider side who just don't want to take care of those people. So that's a huge problem that we have to get past, I think.
I wanted to know, when it comes to data and surveillance of people into linkage to care, or whether they're out of care or lost to care, I wanted to know whether or not some of these areas in Philadelphia, whether or not we are understanding how some areas of zip codes from geological or database surveillance, whether or not we understand whether or not some people have a high risk areas that are so close to areas that are not, but yet there's a chance that they could, and how are we dealing with that subject?
So sort of the distance to care, like...
In reference to geological data and in reference to data surveillance for areas of zip codes or areas that are in certain neighborhoods by communities and surrounding neighborhoods.
Yeah, we've looked a little bit at that. It's tricky because whether someone is close geographically to a health center doesn't necessarily mean that they'll use that facility. We also have to take into account transportation lines, so access to transportation. And there are a lot of factors that go into that type of analysis, so we haven't looked in too much detail at it. That's definitely something probably that we should look into.
One last question.
Hi, I'm Amy Jessup from HepTrek at University of the Sciences. And my question is mostly for Kendra. So I'm looking at the data that we present all over the country about hepatitis C infection and who's affected, where they live, what their age groups are. But we also, before that, show slides of the small percentage of people with Hep C in the country that actually get tested. Right? So programs like your enhanced surveillance are looking at people who have already been screened, right? And we keep learning more about those people who someone has picked out to screen, right? So what I'm wondering is, are there any more active surveillance projects going on in the country that would look for people who aren't already readily identified as at risk? You know, a 20-year-old who gets screened for hepatitis C clearly, likely has some major risk factor that led that doctor to screen them. We don't know what the prevalence is in the unscreened people. Right? Like we don't know what the risk factors are for people who aren't. I know I'm not getting my question out properly, but you know, we keep learning more and more about the people who come forward and get screened, and we're missing, some say 50 or 75% of the people out there. A, do you think that those people have different risk factors and would not present in the same way as the people who are being screened? And are there any programs that you know of in place to do a more active surveillance, to go out and look at people rather than waiting for passive surveillance data to come in?
Yeah, again, we're limited by the size of the population that's Hep C positive. But yeah, of course. My guess is that the people who haven't been tested are probably the absolute most vulnerable populations who are out there. And my guess also is that the risk factors probably are more or less the same. I don't think we're going to identify new risk factors for Hep C transmission, but my guess is that, you know, it's homeless populations, it's populations who are actively using drugs, who aren't accessing any services, who are the ones who are not getting screened and tested. And, you know, getting back to the issue of contact tracing, you know, that would definitely help potentially to identify some people who haven't yet been reported to us with you know, positive test results. But at this point, you know, we really have to use the data we have on hand. Those are the resources that we have to utilize at the moment. Yeah, but it is a limitation.
Okay.
Thank you, Carol. First, I'd like to thank the speakers for 3 wonderful presentations. I don't know about you, but I learned a fair amount today about hepatitis C infections. Now remember, we are all public health people, and public health people are advocates. We need to go out and take the information we've learned this evening, disseminate it to our friends and neighbors, and be advocates for treatment for hepatitis C. So you've got to do your part. Before I adjourn the meeting, I would like to make a few comments about the section on public health and preventive medicine. Now, the purpose of the section is to promote the mission of the college, which is to advance the cause of health while upholding the ideals and heritage of medicine. By participating in the section, you get to meet a lot of regional and national public health leaders and be educated about public health programs and be more aware of public health issues that face our community. If you are not members of the section on public health, I would urge you to pick up an application form outside and join our section so that we can do even more. I will say that the membership for students in public health is free. So there's no reason why you can't sign up. But I do want to thank you all for coming this evening. I want to thank the speakers again for their wonderful presentations. And now let's just sit and network over the social gathering. Thank you for coming.